be able to get there very, very accurately. There's not much chance of going. So even though that's additional aligner series, it's not 50 aligners and it's not 60. They're quite short and sharp with objective in each one. Just like if you were playing golf. You might not get a hole in one, but then every hit that you make, you want to get accomplished, to a certain position. And that's what we do with these more complex cases. And then the final plan that she had is now the finishing. So what do we need to do to finish this beautifully? Just a little bit of root talk here, a little bit, making the upper incisors look great. Final locking of that occlusion. Nothing that's really difficult here. So you can see a complex case the way it's managed. Yes, we had 3 aligner series, but each one had a purpose and it was managed very well. So this is the patient at the first additional aligner series. Remember, we were bringing that one upper right canine across, and we got just to the cross of the bite because there was no overcorrection there in the clean check. And meantime, we're extruding the upper left canine, so it was exposed surgically. And then there's an eyelet there, and you saw the mechanics on the lower, there's a hook there with a retention attachment, so the lower aligner, you don't care, the plane, it stays very nicely on the teeth. I haven't seen yet a canted plane. Maybe it could happen with ankylosed canine, haven't seen it. We tend to control that quite well. So here we are at the scan of that refinement and then at the final. So again, 3 additional aligner series, but a very complex case within a relatively good treatment time, even compared to fixed appliances, and a great clinical result there. I don't think I could have done much better in a much shorter time with fixed appliances. We would have had lingual arch, we couldn't go to the arch because we probably can't, and then we introduce a lot of negative effects. So nice result in a complex case, but looking at additional aligners in a very different way from a mild case, whereas we do 90% is our goal, or even 100%, and then maybe the final short finishing. Complex case is like building blocks, but we don't want, we want short number of aligners, not high number of aligners. So clinician variable. We can bring us to the patient. Now, what about us? We need to know the software that we're working with, the ClinCheck software. That's how we program our mechanics, and we want to keep it relatively simple. We don't want to stress our lives. The whole idea of this 21st century appliance is that it's very clever and it can manage the streamline of orthodontics very accurately. We know it can be measured very accurately and expressed accurately as long as it's worn well. So when we look at our areas of control in the software, there are really only 4 areas that I can change. Right? Can't change the initial occlusion, but I can, as I said, put my effort into the final position, my treatment goal. I can make sure any IPR that's there, I put it there, or I agree with why it's there. It's not there just because I was too lazy to turn it off from the software, even though there shouldn't be any if it's because the default is off. So if you have IPR, it means that somehow you have allowed the software to trigger it. Attachments and aligner features. We used to pay a lot more attention here. Now, as you know, we have these optimized attachments and they're getting better. Yes, there are areas where they don't work amazingly well. If we're extruding a tooth a long way, like those canines, or moving the root of a tooth a long way, if the tooth starts vertical, I think they actually work very well, because the moment of force for just closing space, we'll look at extraction in a minute, is much less than the moment of force when the tooth is already tipped. Then we need a big moment to actually translate. So depends on the initial position of the tooth. How much do we have to extrude? Is the tooth already tilted? How much moment do we have to create? If we start in a favourable position where we don't have to extrude a lot, then I think, or if we start closing extraction site with vertical, teeth already, then I think these optimized attachments work quite well. But we need to assess them. So very little, much fewer changes than what we used to have to do. And then staging, how the teeth are moving. Really the only time I might modify that is extraction or distalization. Not for a class 1 spacing or crowding case where it's simultaneous staging, which is very efficient. Nice small steps all through, like a nickel titanium archwire. So we spoke about final position when we looked at 80, and whatever you get on ClinCheck, whatever you program, if it's doesn't look good on ClinCheck, then it's probably going to be that way. So when we prepare that ClinCheck, it's like right, so that's a transformer, right? And that's what we're doing on the ClinCheck. We have to transform our treatment goal into the final position. And that takes a bit of practice and a bit of skill. So how do we evaluate that final position? Again, usually I'll start, the minute we look at the patient, it's telling us about the ClinCheck. Are the lymphs, do they need to go out? Do they need to stay the same, or do they need to come back in? That's telling you where to tell the technician, or on your prescription form, where that anterior limit is. Usually I start at the lower incisor. Keep the anterior limit at the 4-1, or anterior limit 1 millimeter further than the procline to the 4-1, or anterior limit 1 millimeter retracted from the 4-1. Make a lower anterior limit so that you then work backwards and make a symmetric arch form. Are the canines symmetric, and then the molars symmetric? Once you have a symmetric lower arch, and remember you can even use a bit of lower distalization, which is sort of like making an asymmetric arch wire. We can use lower distalization, get that symmetric lower arch form, and then all we have to do is occlude the upper on the lower with the midlines matching, assuming the lower midline is in the face, in a class 1 occlusion. And then get that smile line right. So starting with the lower arch, unless it's an open bite, then usually I start with the upper incisor, because that dictates what we need to do with that occlusal plane. But most cases, lower arch. Get that nice and symmetric. Then occlude the upper, and then look at that aesthetics of the smile. So getting, a little bit more complex here. This is a patient who came in and we could really go either way with the treatment plan here. She's happy with the profile. We look, it's actually very straight. There is a little mentalis strain here, so a little bit excess overjet here, a little bit of a deep bite, but the profile, the anterior limit, I don't necessarily want to retract her upper incisors. The lower incisors, a little procline. She's mesofacial, so we want about 90 degrees, so a little bit more procline, but really no great change, except we want to relax that chin point, right? And look at the initial inclination of the teeth. The canines and the premolars are actually slightly mesially inclined. The 6-year-old molar is, again, slightly mesially tipped. So that's really important when we're treatment planning, especially extraction or distalization. If we want to choose which one is the treatment plan for us, we know that the facial, the anterior limit is the same in an upper premolar case versus upper distalization to class 1 case. So what do we do here? Her face is going to stay the same, that's our goal. Do we distalize or do we extract? So I presented those treatment plans to her, remove 2 upper premolars or distalization at the whole upper arch. And to do that, which one of those plans takes more patient compliance? What do you think? Extraction or distalization? We tend to think extraction because, that patients don't like it as much, at least in Australia. and they'll do almost anything they can to avoid it. But this patient here was going away for school for a whole year, and so we couldn't see her as often as we wanted. And her mother said, when we explain distalization fully, she understands not just the aligner, but elastics. And pretty much all my extraction cases, I don't need any elastics. So she thought, okay, we're going to extract here because Ava, her daughter, isn't really necessarily going to comply with elastic wear. So, we made two clenchacks, distalization. You can see the molars go back, and then 3, 4, 5, and then the incisors. So it's this kind of staging pattern here. Upper molars, while we're preparing that inclination for retraction. And then for the extraction, we have also a little bit of what we call segmental staging. Prepare the inclination also because the upper incisors need to be retracted. And if we retract, you wouldn't do that with an arch wire. When you put an arch wire in, it's got to be a solid arch wire for retraction, so that will automatically procline, and then we retract. Same with Invisalign, we don't want to just push below the center of resistance on a chip tooth, so we prepare while if we need to distalize the molars, and then we can maintain that inclination while we retract. So here we went with the extraction plan because we didn't want the elastic compliance as well. In this case here, I used conventional attachments, not a G6. I could probably use G6, except we'll have a look at those molars in a minute. She had a deep bite. We've got those bite ramps here, trying to keep, again, are they going to be the only solution for a deep bite? No. But do they help? They help a little bit. So anything that helps in the direction of tooth movement is going to be a digital feature or a liner feature that I like. Putting the root ahead of crown is important when we translate. We're actually mesializing a little bit here, but I want you to focus on what kind of movement is the 1-6. So look where the 1-6 starts. What kind of movement is being programmed? It's actually mesial root tip to extrude that mesial cusp, and it's mesializing. So it's a difficult movement for that aligner to generate, especially short clinic. So we'll keep an eye on that, how that's tracking. Close the extraction site, holding the length or increasing it, prepare the incisors, and then I don't just close both ends at once or retract incisors same time as molars. I'll separate that retraction because with a modern orthodontic appliance that's force driven, we want a low force system. So I'm trying to keep the force very low. Already these attachments are way too big to create that low force system, so I don't want 0.5, 0.5, 0.5 activation. I want 0.25, 0.25, 0.25, 0.25, 0.25, 0.25, so keeping the force as low as possible. Because when you get a high generation force system, you can have a lot of intrusion side effects. You can potentially get some more root resorption than we would have otherwise had. So keeping forces down to 1 to 2 newtons is, a big objective of Invisalign mechanics, which is great. So we're monitoring. She came out of school for a day. In April they have an expiat, and I'm looking here, and the easiest thing is to just give more aligners. Yep, that's great. Okay, off you go. And then the May school holidays, she came out again. And I'm looking and I see, left-hand side already class 1, that's fantastic. What's going on with the right-hand side? Left-hand side looking good, but it's actually in class 1 canine, but the right side, it's not really progressing at all. And in fact, our molar, the buccal occlusion is getting worse. So something's happening here. I'm losing my anchorage and my midline. Look at the midline, it's actually getting worse as we go. So something's holding that left-hand side the right-hand side, space closure, something's going on there. Stop. This is a lesson that is really, really important. If something's not going well, especially when you're tipping a molar, stop, because it's going to take much longer to upright it than it is to stop now, do a digital troubleshooting, create a new clean check, and then go again with a new series of aligners that fits well. Because when you have a tipped molar like that, this attachment is no longer sitting in the aligner. In fact, it may be contributing to that intrusion. Wearing the aligner longer, that doesn't help. That's just defies logic, right? If we know about the material science of plastic, we know that the energy dissipates, even with Smart Track, which is one of the best materials there in terms of modulus of elasticity. Most of the force system is gone definitely by 4th, 5th, 6th, 7th day. Most of the force system is expressed in that 2nd, 3rd day, 1st, 2nd, 3rd, even with Smart Track, and much more with the other materials that are not as elastic. So keeping it in longer, what's it going to do? Nothing, just waste time before you think of a good solution and plan a good solution. Teeth don't need a lag phase to move. That's disproven now in modern tooth biology movements. So we stop. It's the best thing to do. Believe me, it's a hard lesson because the easiest thing to do, hand out a liner. But actually now, in PBS days, it was hard because we would have to take a PBS impression and then, send it off, program. Today, if you do a digital troubleshoot, it's so efficient. It takes 3, 4, 5 minutes to do a scan, and then we can fill in additional aligner order before the patient even walks out of the clinic. So we think about our options and think about why. When we come to troubleshoot for additional aligners, then we have to be a little bit clever, right? We don't want to repeat the same thing twice. Why is this happening? So we try and look and see why. What was programmed there? First of all, I know I had mesial root tip. What does that take? It takes a moment of force. To have a moment of force, we need at least 2 points of contact, a very strong moment, and here we have a very short clinical crown. It's even hard for a fixed appliance to do, let alone an aligner. What else could possibly be causing the right-hand side to not track? What else is happening? We've got a lot of movement on the canine retraction. Mesial root tip, canine retraction. So is there something happening with the canine that's stopping? This is a full unit class 2. So let's have a look and see how easy it is for that tooth to slide through. Now, we've got a bite block there, and even if the aligners out, we have to get past that lower canine. So if it's a full unit, I'll try and create some buccal overjet so we can slide past. Why did the left-hand side work well? We have more buccal root torque here and constriction, so we're constricting actually the arch form, and the canine was not as much class 2. So there was no way the 2, 3, the upper left canine was getting blocked by the bite ramp or just the anatomy of the tooth. So where there's a will, there's a way. We create a recovery, a recovery clean check. Now, what is the easiest way to correct a tipped molar? Actually, listening to Willie Diane, he has a different way of doing it compared to what I use. He actually intrudes the distal. I'm not sure if I want intrusion here. I actually want uprighting. So I reverse. Aligners good at tipping. We want to program movements that the aligner will express very easily. So I'm going to distalize, which is what I need to because we lost anchorage here anyway. So, and that distalized by pure distal crown tip. So we simply ask the technician, upright the 1/6 with pure distal crown tip, maximum velocity from stage 1, and that actually will get that canine where I need it. If I still needed to bring it mesally, which I don't here, then I would say maintain that inclination or add 1 to 2 degrees, not much, just 1 to 2 degrees mesial root tip, and maintain that inclination. So we're not starting like that and trying to bring the roots forward, we're uprighting it and then maintaining that inclination. But here, all I needed to do was distalize, very easy, distal root tip, and then I can go and distalize my canine and my incisor as I had planned. And to do that distalization, we actually don't even need really a new attachment there. So if we're monitoring this recovery as we're going, this is number 14, it's improving, and then number 27, it's improving as well. And here we go, upper and lower 14, that was where we were. Number 27, again, right side's working quite nicely. Her aligners are fitting very well. And coming out of school again, we can see an improvement on that molar. So, and the canine as well. And there she is at the finish. So I guess the point is, when you have a troubleshooting additional aligner series, try and figure out what went wrong in the first one, and don't just repeat that additional aligner series. And it doesn't have to be another 30, it was another 27, very efficient, and actually very simple mechanics to do that. If we keep handing out aligners, we would be in a big mess. We would have a very tipped molar, we would have closed all our space, midlines wouldn't be right. It's much better to stop. So additional aligners should get us closer, right, to our treatment goal. They should not be like this. Let's just take a scan or a PBS and approve another clean check. Approve another clean check without looking. Approve another clean check. Give more aligners. No, we want to spend just that 2 or 3 minutes to have a look and see, was there something obvious there that could have made that clinical result, so that we don't get frustrated by another hit that actually results in no closer to our clinical goal. So programming movements and clean check, just like Ava's program molar movement, was a difficult movement for a short clinical crown and a big root. And when we look at the early extraction cases, it's no wonder that we got the results that we did, because we're programming movements and we're not thinking about 3 dimensions and actually 4 dimensions because there's time. When we push above the center of resistance, what do we get? We get a tip. Unless we have a moment of force, which Invisalign is very good at maintaining that inclination. But if it's an uncontrolled tip, if you don't ask the technician to maintain the inclination, if we just tip, the root will come forward, the crown will go back, and it will express very highly, right? And then we have to think about the occlusion. What's happening not just in the upper arch, but the lower arch. Often we have a deep bite because we have overjet, so we have deep bite. And this retraction happens 90%, 95%, but intrusion, very, very slow, maybe 60%, 70%, depends how old the patient is and how many teeth we're intruding at once. So if the intrusion goes slower than the retraction, very quickly we bump, right? We get an incisor interference. When we get incisor interference, then the posterior opens. And that's typically what we would see. If we have 2 arches doing the same thing, really a very big potential buccal open bite. The other dimension we need to look at is vertical. Like I said, the intrusion happens much slower. Look at these 2 main movements of the incisor. This intrusion will happen, the degree of expression is slower in each aligner, or lower than what we get with a tip or even a bodily retraction. So if this is only expressing at, say, the studies will say 60-70% and the retraction over 90%, they're going to hit very quickly. So what I do in my staging, unless the patient already has a big overjet, which is great, very unlikely we're going to get this incisor interference. If there's not much overjet to start, maximum velocity, I want to get my lower incisors out of the way before I'll start retracting. Otherwise, the same thing will happen. Because the intrusion, again, is slower than the retraction. Think about our mechanics that we see with fixed appliances, and the moment of force we need for tipping is very low. Even controlled tipping, bodily movement 8 to 10. Torque is going to be a very big ask, right? And it's the same with fixed appliances. That's why we have high torque archways. It's why we have high torque or extraction prescription slots, because these movements are slow, also lagging with fixed appliances. We just haven't been able to measure it. Nobody cares. But now with digital fixed appliances, we probably can start to measure it, but nobody cares anymore. They all just want to measure Invisalign because it's very easy to measure. We have a final fixed point and it's digital. So how can we prepare? How can we program a movement that's easier? Think about where the force system is going to hit that tooth. And if it's already an upright or retroclined tooth, we're below the centre of resistance, we're just going to tip. So what can we do? Maybe a parage, if we have more than 4 degrees or more palatal root torque programmed, then we'll trigger a parage. Palatal root torque we know will lag. It's still not going to be 100% of the equation, so we still might get some incisor interference if we don't have much overjet. So what else can we do? We start with exactly what fixed appliances do. You put a bracket here and a big archway ready for retraction, what's going to happen? It proclines straight away. So, and we know that's a tip. Aligners can do that very nicely, so we prepare the inclination. If it's already there, you don't need to worry about this, but if it's upright or retroclined, we do need to worry about this, because we'll get incisor interference. So we prepare the inclination, and then we ask the technician prepare it not by palatal root torque, but by pure crown tip. Pure crown tip, maintain the inclination. The root's now already, because that's an uncontrolled tip, the root now is already behind the crown, and that's what we want whenever we translate, root ahead of crown. Now we just have to maintain that inclination as we're retracting. Of course, we're still going to lose torque, but if we prepare, slightly over-prepare the inclination, depends how far we're retracting. The more we retract, the more torque we're going to lose. But the root was already ahead of the crown in the direction of movement, so the burden to create the moment of force is much less in this scenario as this one or this one. And we can do that really easily, with our 3D mods. So that's the difference, right? Whether we go just pure palatal root torque, that's a low expressing movement with fixed appliances or aligners. Crown tip, labial crown tip, or palatal crown tip is a high expressing movement with our aligners. So if we look at Amelia here, her chief concern is the crowding. She's not concerned about her profile, so she's got crowding. We don't want to increase the anterior limit. If anything, we want to hold or slightly retract it. Maybe in Vietnam it's going to want to be much flatter, but here, we actually like a fuller appearance. It's very personal, right? And that's what we can customize with our treatment plan. But you can see on the set, extremely, bimax protrusive, more on the upper incisors than the lower. Already a warning sign. Before we go anywhere near a scanner or PVS impression, we can see how much overjet does she have here, and she has a deep bite. She is at high risk of incisor interference. So our mechanics have to be very clever. Get rid of the lower incisors, maximum intrusion, maximum velocity intrusion. I don't want it to go simultaneous staging, which will be the default at the moment. I want it to go until I ask the line to change it. It's going to be maximum velocity from stage 1. What does that mean? It means that each aligner has 0.25 intrusion. Is that going to happen? No, it wouldn't happen with an arch wire. We have TADs or reverse curve. but it also means higher force, right? If we have simultaneous, it might go down 0.12, 0.12, 0.12, which is very little force system. When we look at deep bite solutions with fixed appliances, all the force systems, all the solutions have a higher force, a reverse curve arch wire, TAD intrusion, a burst stone intrusion arch, or rickets intrusion arch. They're all higher force than a flat arch wire. So slowing down my velocity doesn't make sense to me. I actually want to do maximum velocity for two reasons. Number one, I want the higher force, still low force, but higher force, than slowing it down. And I want to get the lower incisors away so I can retract my incisors without interfering. So let's plan some mechanics. Key information, right? Look at the initial root inclination. And if we look at the initial root inclination, and why is that relevant? The same, what we just spoke about, the moment of force. The root should be ahead of the crown, at least vertical, preferably ahead, in the direction of the push. We can see that we've got some roots in the opposite direction here. And we can see that on the clean check. Look at the 3-3 here and the 4-3. They're already tipped. Imagine just pushing here. What is going to happen? We need a big moment of force. This is a very long root, the longest root in the mouth on the canine. So that's another warning sign here. But let's have a look and see what I programmed. It's all good in hindsight, right? 20/20 vision, you can see afterwards. But one of the rules that I keep to is never push on a tipped tooth in the direction of the tip. Let me say that again, never push on a tooth that's already tipped in the direction of the tip, because the moment of force is going to be very difficult to create. So you can see here I finish with slightly more open, trying to get my lower incisor roots, lingual. The canine's relying on those little optimized attachments to create that moment of force, to try and get the root ahead of the crown, which I did nicely for the 3-3. See, it's quite vertical when it starts to retract, but the 4-3 was still tipped when the retraction started. So you'll see that causes a few issues. So just a few words on attachments before we come back to Amelia's clean check. Doctors get, asked when do you use a combination solution such as G6 versus customizing, as we saw on some of the other cases. Well, if I always start with optimized attachments, always. So I never request anything particularly special when I put in a clean check, because I want to see what the computer default will give me. The computer default, these optimized attachments are triggered by the movement, beginning to final position. That's what I've worked on, that final position. And then the computer will figure out the mechanics. Then I need to evaluate those mechanics. But I know where the computer has placed an attachment, I need control. So what it's telling me is these teeth need control, and this is the force system that we have generated. All I need to do now is look at that and say, do I think that force system is going to be sufficient? When we have a combination solution, it's a recipe, it's a default, and it doesn't apply to every single patient. Yes, I have G6 patients that have worked beautifully, and I have Amelia here that you'll see in one quadrant it didn't work as well as what it could have. And to me, the bottom line is, and I mentioned this before, where is the start point of those teeth? If you already have a tipped tooth and you're moving like this, even a little optimized attachment cannot create the burden, the moment of force to upright the tooth and then translate it. If we're starting with a tooth that doesn't have to extrude a long way, or just translating, yes, I think the G6 works fantastically with the single point on the attachment and then the counterpoint, which we can't see, although if you've looked at the ClinCheck latest modifications, you can see activation now. They're starting to place those activations so that we can evaluate in all these 4 systems. So what am I saying? It depends on where you're trying to move the tooth and where it started. So when we look at Amelia, yeah, I'm not extruding a long way here. It's really just, translation, the root slightly ahead of the crown. In this 4th quadrant, I have a very tipped canine. So the moment of force, even with the little optimized attachment, is likely not going to be sufficient. So we stop and we evaluate. We do a digital troubleshooting and we take this single scan. So just like with Ava, with the tipped molar, I need to control my lower right canine. So I don't want to repeat the same mechanics. I'm going to try and get my root ahead of the crown. So a little bit of extrusion, a little bit of mesial root tip, mesial crown tip, and it's an uncontrolled tip, mesial crown tip and some distal root tip, just to get it vertical or slightly root ahead of crown, and then translate it. Once the crown is more vertical or slight root ahead of crown, then I start pushing. If you start pushing here, it's just going to keep falling over. So that was the recovery ClinCheck, and as we can see, we're monitoring. She's 29 of that 67. Remember, we stopped just at number 17. It's just that retraction started and we saw some of that tipping. So 29 and then 36. So the canine's actually improving as we're going, which is great. It's not continuing to tip. In fact, it's uprighting. And that left-hand side is working well. The left-hand side was pretty much fine with the optimized anyway. We take a midpoint, I like to take a midpoint pano, make sure if I'm going to do another refinement, another AA series, that I can correct as much as I can. How do we decide if we're finished or not? We spoke about this at the beginning. Same as with fixed appliances. Chief concern, our objectives, is the patient actually even going to wear more aligners, and is an additional aligner order possible? Because as you'll see here, it's actually pretty good. I could stop, right? And everything's looking good. The outcome would be still quite favourable compared to where she started, but it's about getting as good as we can. And in a young patient, she's going to put in the energy to wear the series. And again, short and sharp. It's not going to be another 30. I can't see. We'll see in a moment how many it is. I hope it's not going to be another 30. What do we do now? We can erupt 12-year-old moles a little bit, try and tighten that occlusion. They're being held down by the aligner. Even 6-year-old molars in a growing patient, I'll erupt slightly. Because that would have happened naturally, but because she's been wearing an aligner so well, then it didn't have the opportunity to erupt as much as what it would have naturally. So again, these very small final finishing movements that are going to make, a much nicer clinical result. Whatever you would like to do with your wire bending, the same would apply. So 16, yeah, it was 23 finishing aligners, not too many, probably a few more than what I would like. And now very easily we go into digital retention, ordering, we scan while the patient's just leaving the clinic. I've already ordered, do you want 1 set or 3 sets? We have an option now, and they'll be here in 7 to 10 days. The patient just continues to wear the final aligners, we can virtually remove the attachments or we can take them off at that appointment. It's a very simple process, but I usually take off the attachments if I know I'm going straight into a retainer. I think the virtual removal is probably fine, but I think the accuracy of removing them myself is, well, I assume it's greater. So, you know, it's not perfect, but it's actually a fairly good, solid outcome. It's the 21st century. Eldon, 13-year-old, just another word about attachments. I'll go a little bit faster here, so we might have a bit of time for some questions. I've just got 2 cases to go through. So a little bit class 2, point of view in class 2, division 1, 2 ways we could go with the treatment plan. Definitely my treatment plan was extraction of premolars, but she didn't want it, or the parents didn't want it. So I could align the teeth. The crowding wasn't that severe that it was going to be dangerous in terms of periodontium. But that means I have to get rid of, you know, that crowding without bringing out the anterior limit. So that means high numbers of IPR, which I don't particularly like doing in a young patient, but otherwise her lips would become even stronger, and we can't afford that because she already had a strong profile. So higher numbers of IPR, obviously we need to pay attention. The point I want to make here about the attachments that are getting, let's look at the first one, smaller and smarter. The benefit of the smaller attachments, it's much easier for the patient to insert the aligner right over the top. If the patient doesn't insert the aligner over the top of a conventional attachment, like I had on the canine, this is what happened. So the canine I needed to rotate. Today, definitely optimized attachment. I've got adults with much worse canine rotation. Optimized attachment works beautifully. Even though some of the literature says it's difficult, I'm not sure why. But even a solution like this, which is, you know, the old-fashioned grab it and just push it, it can cause trouble. And the trouble it causes, if the patient doesn't insert the aligner properly over the top, look what happened. The next scan, and you can see the intrusion. So attachments, smaller, smarter, easier to insert the aligner, less generated force system, using less composite, more aesthetic. Now I had to do an additional aligner just to erupt. I should have had an optimized attachment on that canine. Aligner, you know, seating devices are, I think, very useful. I couldn't do what I do without them. Just 2 to 3 minutes, bite, hold, release. On one, that first night, the aligner goes in. So yeah, we had to do additional aligner because I used an old attachment system and we didn't teach the patient. It's much harder to insert over the top. So the old ones don't always work as well as the new ones. Next time I'll show you my very severe adult cases with canine rotation. Old way and new way. The final thing that we can control, final position, IPR attachment staging, is how the teeth move. So we've looked at some staging for extraction and distalization. Selena, chief concern are her canines. She's class 2, particularly on the left side. We know, and we've got chipped teeth here, so some of that correction is going to be from tipping. We know, and we've got a very deep bite, so we need to control that. It's going to be some either extraction or distalization, even though her profile is actually kind of flat. So I'm not thinking I really want to extract in her. Once I get rid of the canines, that upper lip can relax a little bit. The degree of crowding is really in the canines, but the anterior limit, I don't want to change a whole lot. So distalization. We know it works beautifully. We know that clinically. We know that in the literature. It's highly expressed, about 87%. There's a couple of studies between 83 and 87%. I will segmentalize what I'm distalizing because just the orthodontic principles, right? How many teeth moving in one direction? It makes the elastic wear much easier for the patient. They really only have to wear elastics at home and night because I'm only taking 2 teeth back against big anchor segment. Then I'm going to take 3 teeth back while I'm holding the arch length. No anchorage loss. Then the incisors come back, but against a very big anchorage segment. So the elastics really only need to be worn after school and at night, or after work and at night, and it's very nicely controlled. In terms of the deep bite mechanics, we know that I spoke about the velocity. You'll hear some speakers, they want to slow it down. To me, that's the opposite of what we want to do, especially when we have a deep bite in a retraction case. That's going to give us a posterior open bite. We want to get them away quickly, and we want a higher force solution, not a lower force. So maximum velocity from stage 1. The other thing we can do, the automatic G5 deep bite attachments will be placed. We don't even need to think about that anymore. The staging, we can break it down and take the canines and the incisors, or if it's a very deep bite, we can do that in 2 rounds. Canine incisor, what Dr. Simoto and I call froggy, right? In the literature, I've only seen one paper that evaluates this, and it's actually, it was favourable for you get greater expression when you break down the intrusion. Not 6 teeth at once, but 2 teeth and then 4 incisors, 2 canines and 4 incisors. So you don't have to do that, but it's another way of tackling if you have a very deep bite and you're having problems with deep bite. So here we are at 11 months, 11.5. And again, a lot more IPR. She's going to finish with a bit of an overjet there because we do have a bolus discrepancy. There's a little bit more to level on that deep bite, but definitely not as deep as what it was. It was almost 100%. So now just some finishing, and there she is. So we can, definitely use our distalization mechanics, optimum with Invisalign, deep bite mechanics, as long as you think about what you're doing and end up with that great result. Distalization, this is my inspiration, literally, and not, thinking about, can we move? Is it even possible to move a whole arch back? If we do it in segments, I think it works better than sometimes we get a clean check. It depends how many teeth are distalizing and how far. Sometimes a lot of teeth are distalizing at one time, and I don't, then it's going to be the teeth with less mass is actually going to move towards the teeth with more mass. So it looks sort of like this. We also have to think in 3 dimensions, again, in 4 dimensions time, not just the upper arch, but we need to think about taking max velocity. The 12-yaw molar, the lower, can often interfere. And the canine too, the lower canine, as we said, from that AP can interfere, as we saw in the extraction case. So, orthodontics, if you're doing these complex cases, it's a 3-dimensional solution that we need to think about, not just 2 dimensions. So lower 12-yaw molar, lower canine out of the way, straight of the way, and then segmental retraction. And I think I get more expression with my distalization. So key messages, it's the first step that counts, right? The minute that patient comes into the first few footsteps into your practice, it's that connection, because without the connection, it's more of a struggle to get this programmed aligner into their mouth. We're trying to control the patient variables right at the beginning, because we know the more effort, the longer this treatment goes on, the more expenditure we're going to have to make, and the more time that goes on. So these are the most precious things in life, right? Our time. So all our effort goes in at the beginning. Case selection, evaluating the minute they sit down, what might be challenging, what is working for us, tells us about our clean check preparation. The patient's chief concern, obviously, with our treatment goals, looking at the low expressing movements such as translating an already tipped tooth. Let's upright it and make it easy to translate, whether it's a talk on an anterior tooth or whether it's a tipped canine starting to retract or a tipped molar. And effective touch point and monitoring all the way through. So when we modify, our clean check, it's in one way it's become a lot easier because really the focus is on that final position. More and more the attachments are being, the default is more applicable to many more patients and the 4 systems are really improving. But every now and then we may, at the default, just like the bracket slot, is not the solution for everyone. It's the starting point. But we don't want to over-engineer. We don't want to modify too much because we can actually make it worse and make it more complicated. So for me, work on the final position, see what attachments the default gives me. If I think I need to modify them, if I'm extruding a canine a long way or trying to upright a tip 2, then possibly I might correct it. Additional liners happen for many reasons: a short finishing series, stopping something, a 4 system that wasn't applied well in our initial clean check, or a group of additional liners managing a complex case. So there are different forms of additional liners, but think about what we're trying to achieve, definitely a whole in one, and make those cuts as accurate as we can, because that's going to cut down frustration for not only us, our patients and our staff members. So thank you so much.
Thank you so much, Dr. Vicky, for the nice webinar with helpful sharing, with useful sharing. I hope that after this webinar, doctor will be more confident when treatment Invisalign. So we go to the next section is the Q&A section. And before the Q&A section, I will launch a poll so that doctor can share their opinion about this webinar. Các bác sĩ, trước khi mình bước vào cái phần câu hỏi dành cho báo cáo viên, thì các bác sĩ mình dành vài phút để chia sẻ quan điểm của mình, ý kiến của mình về buổi webinar ngày hôm nay. Sau khi nghe chuỗi webinar về Lao Stay của Invisalign, các bác sĩ đã cảm thấy đủ kiến thức để làm Essential chưa, thì các bác sĩ sẽ chọn lên câu hỏi thứ 2.
Are we good? Can you still hear me?
Okay. Yes, I can hear you. So we will enter to the next section, is the Q&A section. The first question is about, in the case with impacted teeth, doctor want to you show more about the way to move the impacted teeth.
So it's very similar to, think about how you would do it with fixed appliances, right? If the canine is in the palate, we need a surgical exposure. So while, and if it was treated with fixed appliances, we would do the same thing. We would place the arch wire on, or send the patient first to the surgeon, have the exposure, put the arch wire on, and then the arch wire objectives would be open space if it doesn't exist for the canine. Same objectives in that first ClinCheck, open space for the canine. Once we have the surgical exposure, we bond on, and I'm sorry I didn't have it on the slide. So I use an eyelet, I'm not sure in Vietnamese, so a button with a ring on it, right? And then I cut a little bit from the ring so it makes a hook. And that is bonded onto the palate, this little hook on that canine. And then on the hook, the patient brings with the rubber band down to the lower aligner, and that's what I kept pointing out on the lower aligner on the ClinCheck. Let's see if I can go back to the slides, so that the patient can hook on the elastic. Where is she? So it's very similar mechanics that I would again do with fixed appliances. Surgical exposure, meantime you're making room. The whole goal is to get some crown length, right, on the canine. So you're just pulling it. The beauty of using the lower aligner, it extrudes the canine, the crown, and towards the outside, towards the buccal, so that we can then, once you've got enough crown length, and that's the trick, right, you want enough crown length, then we can simply include it in the next scan. So here we are. Here you can see a little bit the canine there and the eyelet, the little button, and then the patient will hook the rubber band to the lower aligner, and they do that at home and at night time, not 24 hours, but as much as they can, just to get some crown down. And then once we have enough crown down, then we can take a new scan, and then you saw the ClinChecks from there. So it's a progressive extrusion. So I hope you have the question.
Yes, related to this question, doctor also want to know that in this case you have some additional aligner turn. So in each turn additional aligner, you will have different purpose. So doctor want to know how to divide into some additional aligner.
I think there's no, recipe that's going to work with every patient, because it depends how far that canine is and what angle it is. But basically, in the first ClinCheck, what I'm trying to do is create space, right? And improve the aesthetics, obviously, for the patient, and create space for that canine to come down, because there's no point bringing it down if there's no space in the arch. And that usually just takes 1 or 2 aligner series, because Invisalign again is very good at opening up some space. So you can see on the first ClinCheck, that was the goal. We actually had 2 impacted canines here. One was already erupted, the other one's surgical. Once we have some space, and then we went to the second ClinCheck, now I'm nearly there here. Once you've got the crown, you want to grab it well, and it depends how much crown length you've got. Obviously, the more you can pull down the crown, the better, and that's why I'm lowering the premolars here, because I want to keep as much crown length on the impacted canine, because the moment of force to bring that across needs to be very strong, the retention. So that's why I have a very strong buccal attachment. You can see it's like a 90-degree ledge here, and you can see the pink shadow, which means very high profile, and the same on the palatal. And the position is important near the cusp, near the tip, because that means it's very strong in the aligner, very hard for that canine to escape. So here I think it took me 2 more additional aligner series to bring the canine across, which is probably as much as you would ever need. But the key is getting as much crown exposure as you can, because if you start too early with the new scan, before the patient pulls down the tooth enough, you've got a very short piece of the canine showing, not enough moment to bring it across. So the key is be very patient and get the canine down to almost the whole crown length you have. And you see the whole crown length is there because I still have to translate it far. If I didn't bring it down a long way, then it's just going to tip. So, and then the last clean check is really the finishing, the talk, right? And it's what you would expect. So now you can see the buccal occlusion is fixed. I like it. That's why I'm not moving those teeth. Now it's the talk, because that makes sense. It's a long tooth. We brought it from the palate, so the root got left behind a little bit. Not so much that the aligner didn't fit, but enough so that anteriorly it didn't look as aesthetic as what it could have. So we know we can improve that appearance. The other thing that I didn't mention, so thank you for the question, is laser. So often when we bring these teeth a long way from the palate, the gingival margin, even though we bring down as much crown as we can, as we bring it across, the gum drops. So this patient did have a laser, and that will, if you can do that before the scan, you get even more crown length. So don't forget the adjunctive laser. It will make the crown talk, the final aligner series, to bring that crown in much more efficient.
Thank you, Dr. Vicky, with the exciting answer, with interesting tip in this answer. And maybe because of the time, we over the time a little bit. So maybe one more question, is it possible?
Sure.
Yeah. One more question that Dr. said that you place attachment in the lingual surface of upper incisor. So what the purpose why you put attachment in the lingual surface of upper incisor? And smaller question is that with this attachment, does patient have any difficulty while eating with the lingual surface attachment?
Okay. Thank you again for the question. And yes, so I often do. If you ask any doctor what is the hardest tooth to move with Invisalign, what do they say? It's usually the upper lateral incisor. Okay? And we still don't have a good reason for that today, because we know that this tooth is relatively small, but we do have a favourable crown-root ratio. The other thing we know about the tooth is that the shape is very variable, right? Apart from third molars, we know in the mouth the lateral incisors can be many different shapes. Equilateral, they can be triangle, or often oval without an undercut. So we call it like the watermelon seed effect, right? Where the aligner has to squeeze a lateral incisor to control it. And with Invisalign, even a 2-point squeeze, the tooth can intrude. And we see that so often. Now, Align technology works, and then one little attachment triggered on labial. But for me at the moment, it's a little bit too small. It's still, if we're moving the laterals a long way, then I think it can be a non-fit. If the lateral incisors are not moving a lot, or the canines are not moving a lot, then yes, I will just leave the optimized attachment. So 2 reasons. Number 1, the lateral incisor is the hardest tooth to control. It will just intrude very easily at a very light force. And remember, that force doesn't have to be what we're doing to the lateral incisor, it can be the tooth next door. So if we're derotating central incisors or we're bringing down canines, we have a reciprocal effect that has been measured in aligners. And the tooth is so small, it just disappears. So retention and aesthetics. So when Invisalign first came out, adults, they complained about attachments anteriorly, aesthetics. And the chief concern is usually the forefront teeth. So I don't always put them on the forefront teeth, but usually on the laterals, because I know that they can escape. And if they escape, the aligner doesn't, number 1, they're not in the right position. The aligner doesn't look good. If the front of the aligner doesn't look good with the space, then the patients get shy, the compliance can drop, and then we make a whole big problem. The other side to the question, does it interfere? So